Phil Stasiak. I'm a new staff at the Jewish, and for those of you who remember me, it's great to be back. Today I'll be leading another installment of the POCUS Learning Academy. Okay, and we're going to be talking about pregnancy. I have no conflicts of interest. A couple of objectives. So we're mainly going to be looking at first trimester pregnancy. Because that's what we see in the emergency department. We're going to be looking at the anatomy in normal pregnancy and also in abnormal, in pathologies in pregnancy. And I'm going to talk a little bit about how to integrate POCUS in the management of these patients. Okay, two probes that you can use. You see my cursor?
Yeah, we see your cursor, but just your microphone is kind of a little bit fuzzy when you're moving around. So.
How's this?
Better.
Better?
Yeah.
Okay. So two probes that we can use. There's the transvaginal probe, also called the endocavitary probe. I'm going to talk a little bit less about this one because it's more invasive. Some departments don't have this probe. It takes more time to do this, to do a scan with this probe. And essentially, you can have more or less the same information with a transabdominal probe. Okay, so how are we going to be doing this scan? We're going to be putting the probe, we're going to be abutting the probe right over the symphysis pubis, which is always lower than we expect. Okay, so we're touching it, and I suggest that we start just above the symphysis. I suggest that we start with the sagittal view because we can see kind of everything that we're looking for. And this is what we see on the sonographic anatomy. So we have the bladder over here, and depending on how filled it is, it could be very small, almost non-existent, or it could be actually quite large. And then far field from that, we have this structure over here, which is obviously the uterus, and within it, in this patient, we see the endometrial line. And we can see that there's, at least on this view, there's no free fluid, and there's nothing inside the uterus. If we turn the probe 90 degrees counterclockwise, then we'll see something like this. And depending on where you cut with the probe, you may or may not see the bladder, which is visible here. And far field from that, you see the uterus here. So how do we diagnose an intrauterine pregnancy? That's really the main thing that we want to do for patients that are coming in with symptoms of either lower abdominal pain or vaginal bleeding. Okay, so this is a patient who is around 6 weeks pregnant. And if we look at the sagittal view, we see the same bladder. Now the bladder is much bigger over here. We have the uterus right far field from that. And inside the uterus, we're going to be seeing the intrauterine pregnancy. And so there's a couple of criteria that we need. This is a close-up of that view. So three things to diagnose an IUP. So first thing we need is we need to see is a decidual reaction, which is this hyperechoic change in the tissue that we see over here. And that actually happens quite early on. It happens as early as the 4th post-fertilization day. So even before the patient has noticed that she missed her period, we can sometimes detect this. And then there's a gestational sac that develops, and that's this hypoechoic cyst-like structure that's in the middle here. And the last thing that you need is the yolk sac, which is another ring. You can't see it very well here. And that's why I have another picture here, very, very obvious. So this is the yolk sac that then develops, and you can see it at around 5 weeks by transvaginal ultrasound and about 6 to 7 weeks by transabdominal ultrasound. Okay, before that, it's a little bit difficult. And as the pregnancy progresses, these are the three criteria that you need to diagnose that. When you have that, you've essentially ruled in an IUP. And obviously all of this has to be within the uterus. As the pregnancy progresses, then you start seeing something like this. So there's a structure inside the gestational sac, okay, which is the fetal pole. And this is what later on becomes the baby. And in the middle of this fetal pole, you see this flickering, okay? And that's actually the heart that's beating. And you can start seeing this flickering once the fetal pole is about 5 millimeters or more on transvaginal ultrasound and about 10 millimeters or more on the transabdominal ultrasound. And I think that one useful thing to be able to do in the emergency department for these patients is to measure the fetal heart rate. Okay, and the way that we're going to do that is we're going to press on the M mode button, and when that happens, a line appears on the screen. Okay, and what we're going to do is we're going to align this line through the heart, and we're going to press M mode again, and then we get a picture like this. Okay, and this is the representation. On the x-axis you have time, and on the y-axis is whatever is happening through this line over here. Okay, so I'm going to get just a better representation of this. So this is the M mode representation of a fetal heart rate. Okay, and you can see that there's a repeating pattern over here, and that's the heart that's flickering. And the machine actually has software that can calculate, based on the distance between the peaks or between the repeating pattern, it can calculate the distance and therefore the time that passes in between. So what we're going to do is, once we have the screen, you're going to press on a button called calc or calculation. On some machines, it's measurement. And then you'll have an option to put out fetal heart rate or heart rate. Okay, so one line is going to appear, and we're going to put it pretty much anywhere as long as you can put the second line in the same area of this repeating cycle. Okay, on some machines, you should put it at one interval, but most machines actually use 2 intervals to decrease the margin of error. Okay, and so once you have these 2 lines, there's going to be a pop-up of that shows you what the fetal heart rate is. And the fetal heart rate should always be above 100. If it's below 100, and especially below 90, that's a very poor prognostic factor. But in the early pregnancy, you should expect the heart rate to be around 120, 150. And at around 7 to 8 weeks, it actually goes up to around 150 to 170. Okay, let's look at some things, a little potpourri of pathologies that we may encounter mostly in the first trimester of pregnancy in these patients. So one thing I want to talk about is something called pseudogestational sac. And this is something that's seen often in association with ectopic pregnancy, which we're going to talk about in just a moment. But what it is, it's essentially just a little bit of free fluid inside the intrauterine cavity. And that occurs because of the hormonal stimulation by the ectopic pregnancy. Okay, so there's a little bit of fluid that accumulates, and you differentiate it from an actual gestational sac because you could see that it's got pointy edges. It really looks like free fluid rather than a cyst. Obviously, it's empty because it's just free fluid, and the accumulation of fluid is really in the center of the uterine cavity rather than eccentrically, which is what's seen with just a regular pregnancy. It lacks those echogenic walls, that decidual reaction, and that's what we can see with the pseudogestational sac. Another thing that you may see that is not a normal pregnancy is something called a blighted ovum. Another name for this is an anembryonic pregnancy. And what this is that it's a regular gestational sac. So it's a non-viable pregnancy that has continued to develop, and that is a gestational sac that is basically empty. And the way that you diagnose that is by size. So if you see an empty gestational sac that is over 20 or more commonly 25 millimeters without a visible yolk sac, most likely this is a blighted ovum. And this is actually one of the leading causes of early pregnancy loss, of miscarriage. Oops. This is just a video of it. And you could see, these are centimeter lines over here. You could see that it's just over, I'd say 25 millimeters in its largest diameter. We see that there's nothing inside. Okay, so that's a blighted ovum. And this does not lead to any viable pregnancy at all. Patient comes in with maybe some abdominal pain, but major nausea and vomiting. She's pregnant. Sometimes this could be due to a molar pregnancy. So this is a gestational trophoblastic disease. It's characterized by a very high beta-HCG level, sometimes in the hundreds of thousands early on in the pregnancy. And this obviously is non-viable. And on ultrasound, it looks like this. So some people have described it as a bunch of grapes, or some people say it's a snowstorm. Okay, so this too is non-viable. Subchorionic hematoma. So this is actually one of the most common causes of first trimester bleeding. And what it is, it's a pocket of blood that develops between the uterus and the actual chorion, okay? So it could be next to the chorion here, or it could actually be also abutting the placenta or between the placenta and the uterus. And this increases the chances of spontaneous abortion, especially if it's a large subchorionic bleed, if it's more than 25% of the volume of the gestational sac, or if it's retroplacental, they have worse prognostic factors. All in all, if you see a subchorionic hematoma, it increases the chance of spontaneous abortion from 9% to 18%. So it doubles the chances, okay? And this is what it looks like on ultrasound. Okay, it's right over here. Okay, and so this actually abuts the placenta, which you can see in this cut right over here. Okay, so let's talk about ectopic pregnancy, which I think is the most important thing, the main thing that we want to rule out as emergency physicians in patients that come into the emergency department, either with lower abdominal pain or with vaginal bleeding. It's a diagnosis that's time sensitive and can actually kill a patient, so it's of utmost relevance to us. Most ectopic pregnancies, actually 95% of ectopic pregnancies are in the fallopian tube, but it can occur in many other places. Cervical, these actually tend to can bleed a lot. Abdominal, ovarian. Okay, and so very often we actually won't be able to see the actual ectopic pregnancy, but we see secondary signs of the ectopic pregnancy. And what are those? So we mentioned the pseudogestational sac a little bit earlier on. And this is a video of a patient who has an ectopic pregnancy. We don't see the actual ectopic pregnancy, but we do see maybe a little bit of fluid inside the uterus. So that I would call that a pseudogestational sac. And also, more importantly, we see free fluid around here in the pouch of Douglas, and also near field to the uterus over here. So very likely that this is a ruptured ectopic pregnancy, and obviously this is an emergency, and we should get OBS-GYN involved as soon as possible. Risk factors for ectopic pregnancy. So previous ectopic pregnancy, PID, and surgical manipulation of the fallopian tubes. Those are kind of the main three risk factors for it. So if you have a patient with a suspicion of ectopic pregnancy and with these risk factors, please be careful and get the consultants involved earlier rather than later. Okay. So an approach on how to integrate and how to interpret ultrasound images in the context of patients coming in. So two main chief complaints that I would that I would ultrasound almost every patient for. So lower abdominal pain in females of reproductive age, and also vaginal bleeding in females of reproductive age, okay? And the main diagnosis that I'm always looking for is ectopic pregnancy, okay? So a little case, 19-year-old, she has lower abdominal pain. She doesn't remember her last menstrual period. She denies that she's pregnant, or she doesn't think so. We do a beta HCG. And the bedside ultrasound shows non-diagnostic, non-diagnostic. Back in the day, even before my day, there was a discriminatory zone. So this is a level of the beta HCG at which we should expect to see.
Phil, your sound is cutting in and out a lot. We lost everything just prior to when you put this slide on.
Okay, can you hear me?
Yeah, that's a bit better.
Okay, you can hear me now?
Yeah.
Okay. So back in the day, before my day even, we used to use this discriminatory zone, where at a certain level of the beta HCG, we expect to see an intrauterine pregnancy on transabdominal or transvaginal ultrasound. And the level was different for whether you use a TV or a TA. But since then, this has been disproven. We really shouldn't be using this at all. We know that ectopic pregnancies produce abnormal levels of beta HCG. We can't really predict how much there should be at how many weeks. And so instead of using a discriminatory zone, we should be using the beta HCG mainly for follow-up, and also just to diagnose whether or not there's a pregnancy. So in a qualitative sense. And so when you do the ultrasound, if you see an IUP, you have all three criteria. There's a yolk sac or fetal pole, even better if there's a fetal heart rate, great. You have an intrauterine pregnancy. And essentially, if you see an intrauterine pregnancy, you have ruled out, for all intents and purposes, an ectopic pregnancy, because the chance of there being something called a heterotopic pregnancy, so both an ectopic pregnancy and an intrauterine pregnancy, is around 1 in 30,000. Obviously, this increases in patients who are undergoing IVF, ovarian stimulation, things like that. So be wary in those situations. But in regular patients who have no other risk factors for heterotopic pregnancy, this is sufficient to rule out an ectopic pregnancy. What if we don't see an IUP, but the patient comes in, you know, I'm very regular and I missed my period, you know, 2 days ago, and I'm here to get checked out. So this is a situation where it's possible that there is a intrauterine pregnancy, but we can't see it by ultrasound yet. And in this case, we would basically follow up in 2 days. We would follow the beta HCG, make sure that there's an appropriate rise in the beta HCG level. We can repeat the ultrasound. And if we don't see an IUP and the dates are concerning, if the patient has last menstrual period was 8 weeks ago, 10 weeks ago, and we don't see any intrauterine pregnancy, that's when we start getting worried about ectopic pregnancy. We should get a formal comprehensive ultrasound. We should get obstetrics and gynecology involved as well. Okay, some nice to know things that we can do in the emergency department. So one thing that's nice to know, not essential, is age determination. Sometimes the patient is unsure of her dates, and this is another way that we can confirm the dates with the patient. So in the first trimester, we can use something called the crown rump length, or the CRL, and we measure basically from the buttock or the rump of the fetus up to the fetal head, and the software of the machine will automatically calculate based on this distance, on this measurement, the age, the gestational age of the pregnancy. a little late for the crown rump length. In the second trimester, they use something called a biparietal diameter. Again, we're going to be seeing a lot less patients in the second and third trimester, so that's why these are just nice to know. So they look at the fetus's head and they measure from the outer aspect, near field outer aspect of the skull to the inner aspect of the far field of the skull. And based on this measurement, again, the software will be able to predict a gestational age over here. And in the third trimester, you can use femur length, a head circumference, and also abdominal circumference. But that's a little bit less low yield, a little bit more low yield for us. And that is it. Any questions?
Okay, thanks. Thanks, Phil. There was one quick question. Could the subchorionic hematoma be confused with the placenta? First few hours will look like free fluid, but afterwards?
It could. When blood clots, it becomes more